physician, when we conduct annual physical examination, we may encounter patients presenting with breast mass and hemorrhoids. So to discuss how to handle such cases, we have Dr. Francis M. Roque. He is a graduate of the UST Faculty of Medicine and Surgery, batch 2006, General Surgery Residency and Surgical Oncology, Fellowship Training at the UST Hospital, Active Fellow of the Philippine College of Surgeons, Philippine Society of General Surgeons, and Surgical Oncology Society of the Philippines, active consultant of the UST Hospital, Hospital of the Infant Jesus and Dr. Yanga Hospital, and a medical officer at that Andres Bonifacio Medical Center. So colleagues, let us now welcome Dr. Francis M. Roque.
Hello, good evening. Hello, Dr. Nanette. Thank you for the kind introduction. Admin, can I share my slides?
Yes, Doc.
Can anyone see my slides?
Yes po, Doc.
Okay. Is my audio clear naman po? Just let me know if medyo blurred Sometimes the signal kasi is fluctuating here. Okay, good evening. I'm Dr. Francis Roque. So I will be talking about some of the more common breast and anal problems that most of you encountered during the clinic hours, no? Especially those having their annual PE. Okay, so my topic will be breast and hemorrhoidal diseases, a guide for primary care physicians. Our objective for tonight is one, we will review basic anatomy and physiology of the breast and the hemorrhoidal area, and provide and equip the primary care physicians with knowledge in the initial management, okay, of breast and hemorrhoidal diseases. So let's start with the breast. As we know, the breast is an accessory organ, okay? It's located, both males and females have them. It is more developed in the females. The breast spans usually from the second or third rib up to the inframammary fold, usually from the fourth to the sixth rib. The border extends to the lateral border of the sternum, and the lateral border extends to the medial border of the latissimus dorsi. The blood supply of the breast comes from the internal mammary artery, from the posterior intercostals, and from the axillary arteries. Venous drainage are as follows: the internal thoracic, posterior intercostal, axillary vein, and the Batson's vertebral plexus. The Batson's vertebral plexus is very important, usually for breast cancer. Malalaman natin yan later. Again, another important aspect about the breast is the breast lymphatic drainage. Okay, there are 3 levels. No, for surgeons, no, we always look dito sa 3 levels na to. What are these, no? Ang guide natin palagi is the pectoralis minor muscle. The small muscle underneath the pectoralis major, the chest muscle, di ba? Sa ilalim yan ay pectoralis minor. Okay? Level 1 are all lymph nodes lateral to the pectoralis minor muscle. Level 2 are the ones deep no? Nasa ilalim ng pectoralis minor muscle. And level 3 are the ones medial, okay? Near the clavicle na, medial to the pectoralis minor muscle. These are very important, especially for breast cancer, in managing breast cancer patients. Okay, may case tayo, no? You can answer na lang sa chat box. Okay? Case 1 is we have a 25-year-old male basketball player or an athlete who sought consult because of a right breast enlargement. He denies any intake of any performance-enhancing drugs. On PE, showed a 3 centimeter circumferential enlargement of the right breast. What is your diagnosis? Paki-read na lang, di ko kasi nakikita. And what is your next plan of management? Okay, may mga sumagot na. So, yes, for males, una kagad papasok sa isip natin is a benign condition, no? What we call gynecomastia. Okay? Gynecomastia is defined as an enlarged breast in the male. Okay? They can be physiologic gynecomastia, which occur in 3 stages of male development during the neonatal period, during adolescence, and during senescence. Okay? This is due to the excess of circulating estrogen in relation to the circulating testosterone in the male body. Okay? By definition, any breast tissue measuring at least 2 centimeters in diameter, you can diagnose gynecomastia. Okay? That's by PE pa lang. So what are you going to do if you encounter one patient? Okay? Most patients na pupunta sa inyo, usually they are unilateral. Okay? But there can be patients who will come to you na may bilateral gynecomastia. Okay? So ano una mong gagawin? One, the history and PE, you investigate for one, any sources of estrogen excess. Anong pwedeng maging cause niyan? One, stress. Okay, 2, obesity. 3, any hypogonadism. Okay, or patients taking any estrogen supplements. Okay, those patients with androgen deficiency, mga hypogonadism ulit. Okay, those with syndromes. Okay, Klinefelter, yung mga ganyan. Those with pharmacologic causes, no? That's why I sa sample patient natin I mentioned athletes kasi most, not all naman, there are athletes who take supplements na minsan they don't know that contains some hormones, no? Like estrogen, okay? Or some inactive hormones that that can be converted into estrogen, no? That can cause gynecomastia or any systemic disease. So first to do is you request for an ultrasound and yes, nabasa nyo tama, mammogram. Okay, we also do mammogram for males, but by experience, it's very difficult. Okay, very painful for the males. No, so most of us we resort to ultrasound. Okay, why? Okay, for males, no, syempre, if you have enlargement of the male breast, hindi, it's not safe na pala, gynecomastia lang yan. Okay, based on your PE, let's say kung na nakapa mo, you have a dominant mass. Matigas talaga siya. Matigas, irregular, ganyan. Then you notice there are some skin changes, okay? Isipin mo kagad, teka, baka hindi to gynecomastia. Okay? Baka mamaya, this can be male breast cancer. So, you request again for ultrasound, no? And mammogram, or better yet, you can request for an MRI, okay? In order to characterize the mass and the male breast, okay? So, mas guided ka sa management mo. If sinabi nung mass, may bukol talaga siya, so don't hesitate na kagad. Don't tell the patient na, observe lang natin. No, you immediately refer them to your friendly neighborhood surgeons. Okay? Kasi baka mamaya, male breast cancer na siya. Okay? But if it's just gynecomastia, okay, how do you treat it? No? One, you stop the offending drug if the patient is taking any supplements that can cause the gynecomastia, especially those patients na bilateral. Okay? 2, you can initiate endocrine therapy. No? Gynecomastia is due to estrogen excess, so you can give
Laboratory and diagnostic need.
Okay, you can give anti-estrogen in the form of tamoxifen. Okay, it's given 1 tablet once a day. Okay, and if there's in doubt, again, you refer to surgery kasi some of the gynecomastia, especially yung mga bigger ones, no, mga more than 2 centimeter, 3, 4 centimeter, they might need to undergo definitive surgery or subcutaneous mastectomy. Okay, just to solve your questions na lang later, ha? Okay, case 2. We have a 30-year-old female who came to you because of breast tenderness associated with erythema and fever. She is 5 weeks postpartum and has been having difficulty expressing or emptying her breast of milk. Okay, what is your diagnosis? 5, 4, I'm giving you 5 seconds now. 3, 2, 1. Okay. We're now going to talk about breast infections, okay? Bakit yun ganun ang example ko? Okay? Kasi this is one of the more common na pupunta sa atin, Doc. Sakit ng breast ko, maga, mapula, mainit, ganyan. Doc, nilalagnat na po ako. Okay? So, one, by history, no? Usually breast infection, these are very common among usually mga ano yan, lactating women. Okay? Especially those individuals na tamad mag-express ng milk, okay? Or hirap, no? Hindi naman tamad, sorry, but most of the females na hirap mag-express o mag-empty ng kanilang breast, okay? The milk serves as a very good media for bacterial growth, okay? More common pathogens that we encounter usually are the Staphylococcus, the Streptococcus. These are skin pathogens. Sometimes you also encounter tuberculosis or fungal. Okay, so how do you diagnose breast infection? Again, physical exam, and you junk it with an ultrasound. Never kayo magpamammogram ng patient with breast infection unless gusto nyo masipa. Okay, it's very, very tender. Okay, so ultrasound pa nga lang minsan nahihirapan na silang gawin kasi masyado siyang masakit. Okay, so ultrasound pa lang okay na siya. So what do you do kapag usually babalik yan sa iyo? Doc, pagbalik ng ultrasound, sasabihin sa inyo, there's a mass or an abscess, okay? Then, you need to do the definitive procedure, okay? If there's an abscess, okay, or by PE, mapalpate mo, meron ng fluctuant area, okay? May mass, okay? Most of them, hindi pantay yung breast. Yung kabila, emptied. Pero yung kabila, sobrang engorged. Then, mapula, erythematous, tender on touch, warm, then there's a fluctuant mass, okay? If you have the skills to do it, you can do incision and drainage, no? It will relieve the patient of the tremendous pain, okay? Or you have the gadget naman, if you have the facility, you can do ultrasound guided aspiration, okay? We always send specimen for GSCMS, though we know what the more common type of pathogen, no? But we always send specimen for GSCS pa rin. Okay? Pag nakita kayo ng patient, okay, with breast abscess, you start always with broad spectrum antibiotics. Okay? Ako, lagi kong ginagawa, if the patient is just mastitis lang, no? Meaning inflammatory lang, wala akong nakakapang fluctuant area, I can start the patient with an oral antibiotic, broad spectrum antibiotic, and adequate pain relief. Pinaka-importante lagi natin nakakalimutan, adequate pain relief. You give the patient NSAID, lalo kung wala naman silang allergy, wala namang contraindication with NSAID, NSAID pa rin tayo. There are patients kasi iba bibigyan lang nila ng mga opioids like tramadol, mga ganyan, those with tramadol, paracetamol, minsan kasi kulang sila, no? Kasi you want the anti-inflammatory effect of the NSAID. Malaking bagay siya, okay? But if you have fluctuant mass na, okay? Pagkapa mo sa breast, sobrang engorged, halos puputok na, then meron ng minsan skin changes yung mga yan, yung pagkapa mo malambot na at very fluctuant na, huwag nyo nang pauwiin yung pasyente, immediately admit the patient, start them on broad spectrum IV antibiotics, IV pain relief, okay? Then immediately you refer them to surgery. Wait lang, sorry. Naka-off ata yung camera ko. No? Sorry, I'm using kasi an iPad. So I think iba ata yung interface with an iPad sa Zoom. So naka-off yung camera kasi kapag ka naka-share screen ako.
Yes po,
Okay.
Doc. Iba po yung lumalabas na picture.
Nakikita niyo yung slides ko naman? Anong picture yung lumalabas?
Yes po, Doc. Kita po yung slide. Yung sa speaker lang po yung iba yung picture.
Walang picture? Walang picture.
Pero yung slides po okay naman po, Doc.
Okay. Yung picture ko ano lumalabas? Sorry.
Wala po. Wala po.
Okay. Wala. Kasi iba yung interface kasi sa iPad. Sorry. Sa laptop kasi pwede eh. Sa iPad kasi hindi eh. Okay. Anyway, the slides naman mas importante naman. Okay. Okay, case 3, you have a 19-year-old female who came in because of a tender mass at the left axilla associated with a purulent discharge. Okay, sometimes may darating sa inyo, Doc, may bukol ako. Saan? Dito, Doc, sa kilikili. Okay, then pagtingin ninyo, magang-maga yung axilla, tender, then sometimes may discharge na rin. Okay, what is your diagnosis? 5, 4, you can type in sa ano? Okay. Answer? Tama, no? So, most of the, tama naman, hidradenitis suppurativa. Okay. What is hidradenitis? Okay. It usually occurs in the nipple areolar complex or more commonly sa axillary area. Okay. Hindi lang siya sa females. Okay. I've seen a lot of hidradenitis sa males then. Okay. So this is a chronic inflammatory condition that originates within the accessory areolar glands of Montgomery sa nipple areolar complex or more commonly from the sebaceous gland complex of the axilla. Okay? This, para siyang no? Pinakamadaling explanation here is pimple siya na nasa axillary or nipple area. Okay? So these are common among patients na one, nag-shave ng axillary hair. Okay? Those na nagpa-pluck. Okay? Or nagpapa-wax. Okay? Then, common din siya doon sa mga individuals who uses products, no? Deodorant sa mga ganyan or axillary plus skin products sa axilla that leaves residue. Nabablock yung exit ng sebaceous glands. Then, nagkukos sila ng blockade, then nagkakaroon ng inflammatory condition. Again, sweat, sebum, these are good media, no? Para magkaroon ng bacterial growth. Okay? So, how do you treat hidradenitis suppurativa? Okay? In the initial stage, no? Kapag medyo maga lang siya, on PE, pagkapa mo, hindi naman fluctuant, matigas, may mass, mapula, tender, okay? So, you can treat it again, NSAIDs, pinaka-importante, okay? Then, broad spectrum antibiotics, second importante din. Then, kapag may fluctuant areas, you do drainage, okay? Do you need to admit patients? Depende, okay? If napansin mo, wala namang fluctuant area, matigas, okay? What I do, I start them with NSAIDs and broad spectrum and oral antibiotics, okay? Then, wala naman history ng fever, okay? Then, I send them home. Ask them to follow up after 2 days. Close follow-up pa rin, okay? Kasi sometimes, they develop abscess after 2 days despite antibiotics. So you want to see them after 2 days just in case magkaroon ng abscess, you might need to drain, you can admit them. Okay? Or in the onset naman, pagkatingin mo, fluctuant area, malaki, may bukol. Bisa nakakita tayo malaking bukol sa axillary area. Okay? Huwag nyo nang pauwiin yung patient. Advise them admission. Okay? Start with IV antibiotics, especially those patients who are having fever na or pa-request ka ng CBC, mataas ang white count, okay? You admit them. Start IV antibiotics, start NSAIDs, okay? Then, refer to your surgeon and so we can do incision and drainage. Okay? Then, you advise patient, okay? Siyempre, pag gumaling na yan, babalik yan sa'yo. Doc, paano pag naulit? Kasi hidradenitis, ang sakit niyan is recurrent, okay?
Recording stopped.
Ulit ng ulit, okay? I think the recording stopped pata. Okay lang yun? Can I continue?
Wait lang po, Doc.
Okay, sige po.
I-on lang po namin ulit.
Sure po.
Recording in progress.
Okay. So,
Eh,
once
thank
bumalik
you
sa'yo,
po.
patient. Okay, thank you, Dr. Once bumalik sa'yo, patient, Doc, healed na, okay? What do I do para hindi mag-recur or to lessen the chance na mag-recur siya? So, one, you advise them on hygiene care, okay? Axillary. Sometimes, syempre, the hair, the axillary hair, syempre, it's part of hygiene. We need to remove that. Best pa rin talaga is those na hindi mag-cause ng so much trauma, no? Like, medyo mahal, but laser, okay? Yun ang pinakamaganda pa rin talaga, no? Plucking, waxing kasi they can still leave, traumatize the sebaceous, the pilosebaceous unit. So, pwede pa rin mag-cause ng recurrence, okay? Then you also advise them to use, if they really need to use deodorants, no? Or skin product for the axilla, they use those that does not leave residue, no? Yung mga uso kasi like the roll-ons, the stick, or sometimes the tawas, literal na tawas, they will leave residue. Uulit lang yan, vicious cycle lang, uulit lang yan, papangit na yung kilikili ng pasyente niya. Okay? So advise na may mga nabibili naman ngayon na spray that leaves almost no residue. Okay? So yun yung best advice niyo for patient. Then, maintain care, proper care, no? Dry lang palagi, yung mga ganun. Okay? Do not use powder din pala. That's one cause din. That can cause hidradenitis suppurativa kasi it can also cause blockage. Okay, next. Sometimes patient will come to your clinic, Doc, may nipple discharge yan, napansin ko. Okay? So, you investigate, no? Is the nipple discharge bloody or non-bloody? Okay? If it's non-bloody, if it's bilateral, okay, usually this can be due to a physiologic cause, no? Like one, investigate for hyperprolactinemia. It can be caused by pituitary tumor, hypothyroidism, or sometimes medications then. Okay? Eh, Doc, yung nipple discharge ko, medyo may dugo eh, no? Then, isang nipple lang, okay? Then, they are persistent or recurrent, okay? Then, you investigate, baka pathologic to, no? But most of the nipple discharge naman, usually, they are benign, okay? Pag benign, investigate, usually isipin mo kagad anong papasok sa isip natin pag benign nipple, bloody nipple discharge, more common pa rin is intraductal papilloma, okay? But you need to investigate further kasi bloody unilateral nipple discharge can be a sign of malignancy. Okay, so what do you do? Okay, as primary care physician, you can request for an ultrasound again or a mammogram, no? Kasi usually may bukol yan na pinanggagalingan. May source yan na pinanggagalingan. And they can be seen by ultrasound or mammogram. Again, you need ultrasound and mammogram again para once you refer to a surgeon, the surgeon already has a roadmap on where to look, no? Masyado marami yung docs eh. Mahirap hanapin yan. So, okay, we need to localize. So, ultrasound and mammogram can help us with that. Okay? Do you do cytologic studies, no, of the nipple discharge? Not recommended because of very low diagnostic yield. Sayang lang. Gastos lang. Okay? So, every time you're in doubt, you refer to surgery. Okay? Again, reiterate ko, nipple discharge, this necessitates further investigation because they can be a sign of an underlying malignancy. Although, majority pa rin are still benign. Clear? Next case is a 65-year-old single, newly gravid, came to the clinic because of a breast mass. Okay? So, nasa breast mass na tayo ngayon. PE, the mass is 3 cm in size, hard, and adherent to the surrounding tissue. Then you note dimpling around the mass without nipple discharge. What is your next plan of action? Okay, bago tayo pumunta na lang dun sa action muna. Breast mass, pag pumunta sa clinic, okay, lalo na kung elderly yung patient or patient 40s, ganyan, premenopausal, isang ano kagad yung kailangan nating i-rule out, okay? Malignancy or breast cancer, okay? So by PE pa lang, you can differentiate them na, no? Whether the mass is benign or malignant, no? Most benign mass, they are soft, no? Or sometimes they are rubbery, okay? On palpation, they have a discrete and regular margin. They are well encapsulated, okay? Usually they are mobile. They are not adherent or attached to the surrounding tissues. More likely they are tender, no? Especially during period, lalo mga menstruating patients ninyo. Most of them does not present with nipple discharge, and there should be no skin changes, no? On the other hand, malignant masses, usually they are firm or rock hard, okay? They are very irregular in shape, no? Indistinct margins. Most of them are attached to the skin or sometimes to the chest wall. Sometimes no, they are fixed, no? You cannot move them, okay? Less likely to be tender, though pain is non-specific talaga, no? Some of them may present with bloody discharge, and their skin changes in the form of dimpling, hue de orange, no? Nipple retraction can be an initial sign of a malignant mass, though hindi lahat, okay? So when we talk of breast cancer, again, screening pa rin, okay? Prevention pa rin is better than cure, okay? So screening is done and is of greater value for patients who are most likely to develop breast cancer, no? Meaning those who are high risk. And for them, early treatment is very effective in order to reduce mortality. So yung mga widely used na ginagamit natin tool, no? To calculate the breast cancer risk, no? Narinig nyo na yan, I'm sure, Gale model, no? This includes yung ang composition lang ng Gale model is the patient's age, the race, ethnicity, any history of personal breast cancer, age at the onset of menses, or tawag na dyan, menarche, okay, arity, and relevant first degree family history, okay? Again, I repeat, relevant first degree family history, okay? So, ako personally, I really use the Gale model, though we include this, no, sa history. So, how do you determine the risk, no? Mga major determinant ng high risk, no? Pag meron tong mga to, ay, teka, high risk yung pasyente ko for breast cancer or developing breast cancer, okay? So those with personal history of ovarian, peritoneal, or breast cancer, okay? Those with family history, no, of ovarian, peritoneal, and breast cancer, no, especially in the first degree, okay? First degree, no? Those with ancestry associated with BRCA1 or 2 mutations, usually yung mga Jewish, di ba? Those with non-carrier pathogenic mutation for hereditary breast or ovarian cancer syndrome in the self or in their relatives, okay? Actually, hereditary breast and ovarian cancer is a syndrome, no? May ganyan talagang syndrome. If ni-research niyan, meron talagang hereditary breast and ovarian cancer syndrome. It's a syndrome sa usually late onset na yan nag-occur. And these patients usually are BRCA positive and they will develop either breast or ovarian or both. Okay? Those with previous breast biopsy indicating high-risk lesions. For example, may patients ay pumunta, Doc, na-biopsy na ako before eh. Oh, ano yung biopsy mo? Doc, sinabi ng atypical, no? Anything with atypia. Okay? High-risk lesion, okay? Those with DCIS, ductal carcinoma in situ, or globular carcinoma, these are all high-risk lesions, okay? Those with history of radiotherapy to the chest wall, okay, between the age of 10 to 30, okay, these are all high risk. So high risk, you have 20%, more than 20% chance of developing breast cancer, okay? High risk meaning one of those na mentioned natin above, okay? Moderate risk, 15, usually mga 15 per less than 20%. Okay, these are women with breast cancer in the first degree relative, but without a known genetic syndrome. Okay, and those with average risk, less than 15% chances of developing cancer in their lifetime. Those women with no risk factors. So, as oncologists, no, Surg Onco, Med Onco, okay, we usually, ito isa to sa mga Bible namin, the NCCN guidelines. You can easily download this on the internet. Mag-register lang kayo. It has a complete lineup for cancer from head to toe. Okay, they include screening and diagnosis and prevention. Okay, so the 2022 version ng breast cancer screening and diagnosis. Okay, if you're going to look at the medyo busy, no, but focus not only on the first line muna. Okay? Patient came to you, asymptomatic, meaning walang mask na nakakapa. Dok, wala naman ako nakapa, annual PE lang. No? How do you screen patients? Okay? So, asymptomatic, wala ka ng mga risk na nabanggit natin kanina. Okay? Put the patient on average or no risk at all. Okay? If the patient is average risk, okay, you divide the age. Okay? Greater than 40, less than 40, but not more, but not less than 25. Okay? So patients who are 25 to 40 years old, okay, what do? You advise them yearly clinical breast examination or yearly clinical visits every 1 to 3 years pa nga, and monthly breast awareness. Breast awareness is self-breast exam lang. Hindi ba lang nila? Pinaganda lang nila. No? But breast awareness is self-breast exam. Okay? Monthly. Okay? But if your patient is more than 40 years old, okay, you advise them one annual clinical encounter. So you need to see them annually. Okay? Annual screening mammogram. Okay? Yung pa rin na pinaka-recommended. Not ultrasound, but mammogram. Okay? Some of us, we combine mammogram and ultrasound. Kasi sometimes, there are breasts, no? Especially those breasts that are very dense o yung mga medyo large breast females, no? Medyo bumababa yung sensitivity of detecting non-palpable masses ng mammogram, so we need to adjunct them with ultrasound, no? Or better yet, if available sa institution ninyo, you request for tomosynthesis, okay? Tomosynthesis is just 3D mammogram, okay? Mammogram kasi is two-dimensional only. You look for the craniocaudal and the mediolateral oblique view, no? But tomosynthesis, para siyang CT scan ng breast, no? Parang ganun lang, no? Not CT scan, but X-ray pa rin siya, but it takes a 3D picture of the breast. So umiikot yan. Okay, hindi kagaya ng mammogram, pinipiti lang niya, di ba? So two-dimensional. Tomosynthesis, iniikot niya yung buong ng breast mo, no? If available, that is more recommended kasi mas maganda siya. Okay? And syempre, monthly breast awareness. Okay? So that's for average risk individuals. Okay? Or general population natin. Okay? But for those with increased, ito. Okay, let's go to muna to mammogram. Okay? Minsan darating patient sa'yo, no? Doc, may mammogram ako, pwede mo bang interpret? Tulungan mo naman ako. Okay? So, screening mammography, okay? Meaning, sorry. For screening mammography, what do you do? No? For those patients 40 to 49 years old, you can request yearly mammogram. Okay? Example, 40 to 49, masipag yung patient mo, bumabalik sa'yo talaga yearly papamammogram. Negative naman siya. So once nag-50 na siya to 74 years old, wala ka pa rin makapang-mass, you can do mammogram every 2 years na. Okay lang yun. Okay? Then, ibahin mo lang kapag biglang advice sa patient, okay, pag may nakakambukol, balik ka kagad kahit wala pa 2 years. Okay? Don't wait for 2 years. Okay? 2 years na kapag wala siyang makapa. Okay? But if patient is more than 75 years old and life expectancy is at least 10 years, again, you can request for mammogram, screening mammogram every 2 years. Ito pa, sa pinaka-important is primary care physicians, you need to know how to interpret the mammo or the ultrasound. Same lang naman sila, okay? We don't just rely on the reading na there's a mass at 3 o'clock position. Di ba? Ganun ang usual mababasa ninyo eh. There's a cystic mass or hypodense mass, no? Noted at 3 o'clock position, measuring sa ganitong centimeter, ganyan, 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 ganyan. Okay? Hindi lang kami nagre-rely doon. We rely on the characteristic. Okay? So, dito mo siya makikita. How do you know na maganda yung pagkakagawa ng mammogram tsaka ng ultrasound? If you have the BI-RAD scoring. Kasi sometimes, may mga ultrasound, breast ultrasound, and mammogram na walang, sadly, wala talagang BI-RADs eh. So, minsan hindi ko maintindihan. But, para makita mo na maganda, check mo yung BI-RADs. Okay? So, paano mag-interpret ng BI-RADs? No? BI-RADs is short for breast imaging radiologic score. Okay? There are 7 scores, okay, or categories: 0, 1, 2, 3, 4, 5, and 6. Okay? So again, 0 meaning inadequate, no? Like sasabihin, babasahin mo doon, BI-RADS category 0. Huwag kang makumpante. Ay, oy, 0 ka naman. Okay na yan. No, 0 is incomplete assessment, no? You need to request additional imaging. Nagpamammogram ka, paggawa ka ng ultrasound or MRI kung kaya, or tomosynthesis. Ganon. Okay? So 0, hindi siya okay lang. Kulang pa siya. Okay? BI-RADS 1, 2, and 3. Ito yung gusto natin makita. Ito rin yung gusto ng mga patient. These are benign or negative. Okay? 1 is negative. No cancer detected. 2 is benign. Okay? Almost 100% benign yung mga nakikitang masses. Kahit may bukol, benign pa rin siya. 3 is probably benign. Okay? Mga mga nasa at least 95% chances benign ito. Okay? Less than 5% lang yung chance or 2% na lang yung chance na malignant siya. Okay? But ibang usapan once na BI-RADS category 4 and above. Okay? 4, 5, 6, you need to take action. Okay? 4 is probably benign. Okay? Tatlo yan. 4A, 4B, 4C. No? Anong difference nila? Iba-iba lang. Tumataas, A to C, tumataas lang yung chances na likelihood of cancer. Okay? 4A, less than 10% chance. 4B, around 50% chance. 4C, medyo almost malignant na yan. Okay? So, pag BI-RADS category 4 ang reading, that's probably benign, probably malignant. The next course of management is you do biopsy if you can do it. If not, you refer to your friendly neighborhood surgeons. Okay? Next is BI-RADS category 5. Okay? 5, it already has the radiologic sign that this is malignant, like yung mga calcifications, fine calcifications, speculations, yung mga ganyan, irregular, okay? More than 95% cancer ito, okay? Yung mga ganito, do not advise them, we can repeat it after 3-6 months. No, do biopsy kagad. Kailangan kagad maoperahan, okay? Kasi malignant na ito, okay? Lalong-lalo na pag BI-RADS 6, okay? BI-RADS 6, minsan kasi nauuna yung biopsy eh. Lalo na kapag palpable yung bukol, nababiopsy ng ibang doktor, then lilipat sa'yo kasi gusto humingi ng second opinion. Okay? Siyempre, ikaw naman, you follow the proper, you request for an imaging. Okay? Pag may bukol na, bakit kailangan magpa-imaging? Kasi minsan, there are other areas, no, na kailangan i-evaluate ng imaging. Okay? For surgeons, importante yung kasi we also offer breast conservation surgery na. Meaning, hindi na kailangan tanggalin buong breast. At kahit may bukol ka, we need to investigate kung yung ibang area pwede naming iwanan or not. Okay? So, minsan pupunta sa'yo, may biopsy na, then you request na nauuna yung biopsy than the mammogram. BI-RADS category 6, cancer is already present na. Again, surgery na kagad ito. Okay? Surgery, basta you refer to an oncologist kagad. Okay, if ever your patient falls to those individuals with increased risk, no, yung na-mention natin kanina, okay? Ano nang gagawin niyo? Okay? Those with increased risk, no, or high risk individuals, okay? One, you refer them immediately to surgeons or to surgery, okay? and you refer them to screening clinics, okay? Kasi we need to consider genetic testing na, no? BRCA1 and BRCA2. It's available in the Philippines, okay? Medyo mahal lang nga siya, no? I think BRCA1 and 2 cost around mga nasa 150 to 200,000 per individual test, okay? And you can offer them risk reduction treatment, okay? So those with BRCA mutation carriers, no? Tinignan niyo dito sa diagram natin, no? BRCA1 and BRCA2, their lifetime risk of developing breast cancer is very high, okay? More than 50% of them will develop breast cancer. Males, no? Pag tinanong kayo, anong mas common mag-develop ng male breast cancer? Those with BRCA2 positivity, no? Up to 9%. Mga BRCA1, pwede pa rin, pero mababa lang. Kapag BRCA2, males, mataas. Okay? Females, both mataas. Okay? And again, isa pa, napansin niyo naka-bold, palaging magkasama yan eh, breast and ovarian. Okay? So those with BRCA1 and 2, you need to refer them also to your to the gynecologic people. Okay? Kasi most of them, like 60% of them, can harbor ovarian problems, no? Ovarian cancer. Okay? So what can we offer pag patients natin are BRCA mutation carriers? Okay? We can offer one, like what Angelina Jolie, siya yung pinakamagandang example, no? Did, no? Risk reduction surgeries, no? We can offer prophylactic mastectomy with or without reconstruction. Okay? We can also offer risk-reducing salpingo-oophorectomy for those patients with ovarian cancer, or kung wala kang ovarian cancer but patients with breast cancers, we can offer risk reduction salpingo-oophorectomy. Okay? Then you do intensive surveillance for breast and ovarian cancer. Hindi na siya yearly, no? Pag mga BRCA, we do evaluation kahit every 6 months, or sometimes ako nga ginagawa ko pa every 3 to 6 months ang follow-up namin talaga. Talagang very intensive, no? Kasi mabilis silang mag-develop ng cancer, okay? Or some patients may end up doing chemo prevention. So why is it important to refer them early, no, to surgeons, okay? Kasi how do we manage breast cancer management, okay? One, you need to get a biopsy, okay? Ideally, you do it using core needle biopsy, no? We have a special, hindi siya yung syringe na ginagamit natin. We have a special gun, no? Usually malaki yan, gauge, I think mga nasa 21 to 23, 21. No, mas malaki pa. Okay? But hindi yung needle na ginagamit, hindi syringe, no? That's fine needle. But core needle is malaki. It's a large bore needle. Talagang humihiwa yan. Medyo masakit. Okay? But it's very good, no? Or kung mahirap kumuha ng core needle, you can do excision or incision. Okay? Then, syempre, pag cancer siya, they need to undergo the definitive surgery, no? Like mastectomy or MRM, tatawag natin, okay? With or without reconstruction, okay? Or what we offer patients na, BCT or breast conservation therapy, surgery or BCS, no? With sentinel lymph node dissection, no? Sentinel lymph node dissection, you get the, before what we're doing is complete axillary dissection. Level 1 and 2, nililinis namin yan. Okay? With sentinel lymph node, okay? You inject dye dun sa breast, sa mass, okay? Then you wait for the dye to migrate to the first 2 or 3 lymph nodes dun sa lymph node chain, okay? Then you get those lymph nodes, send it for frozen section for pathology, and they will check if there's already lymph node involvement, okay? If there's no lymph node involvement, they can go away with the complete axillary dissection. Kasi nga, we wanted to decrease daw, no, the morbidity ng lymphedema because of the axillary dissection, okay? Though very few kasi proper kayang gawin, big hospitals kaya, no? Fortunately sa HIJ kasi wala tayong gamit, okay? And we send the frozen section outside pa, which may affect the positivity, no? So, mastectomy with axillary pa rin ang ginagawa natin. Okay? Acceptable pa rin naman siya. And again, if patient is breast cancer positive, syempre, most of them will need to undergo adjuvant treatment like chemotherapy or targeted therapy, no? Targeted therapy in the form of yung mga sumab, okay? Trastuzumab, pertuzumab, okay? We call them targeted therapy kasi they target specifically the cancer cells, no? Unlike the chemo, it's systemic, no? Targeted systemic pa rin, no? But it has the less yung side effect as compared to the chemotherapy, the regular chemotherapeutic agents, okay? Some patients will need to undergo radiotherapy. Not all patients, but there are certain indications for radiotherapy. And again, yung pinakamasayang part na is hormonal therapy, no? Yung mga maintenance ng mga breast cancer patients natin, okay? But hormonal therapy will only work for breast cancer patients who are estrogen and progesterone positive, okay? If they are ERPR negative, okay, the chances of the medication, the anti-estrogen working is less than 5%. So, almost hindi na lang natin binibigay. But if they are either ER positive, PR negative, or ER-PR positive, binibigay natin kasi maganda ang response nila and maganda ang anti-cancer treatment nila. So hormonal therapy can be in the form of we give tamoxifen for mga premenopausal, for mga younger patients, those who are still menstruating. Pero kapag elderly na, no, those mga menopausal na, tamoxifen pa rin can still work, no, but not as good as yung mga AI natin, yung mga aromatase inhibitor in the form of yung mga exemestane, anastrozole, letrozole, okay? There are newer hormonal therapeutic drugs, no, na lumalabas ngayon, like yung mga fulvestrant or faslodex, okay? There are injectable that can be given only once a month. Ang medyo downside lang ng injectable, no, or the fulvestrant siya, no? Per treatment can cost the patient ang mga nasa 25 to 30,000 compared with the AI, which costs around mga nasa 3,000 to 5,000 lang per month, no? So medyo malaking difference, but they are very good, very good. Okay, take home lang natin sa breast always, okay? You can manage them, okay? You can give the initial management, but always when in doubt, if you think you need additional management, okay, you always refer them to us, to the surgeons, okay? Next case, okay? Last case to, no? We have a 42-year-old male clerk, no? Came to you because of a painful masses in his anus or in his anal area. Usually happens after defecating, no? Sometimes associated with blood streak stools, okay? So, ano to? Medyo giveaway na to. What is your impression? So, hemorrhoids, no? Hemorrhoids are normal part of the sphincter system, okay? So, they are divided into two, no? There are internal hemorrhoidal plexuses, no? We use the dentate line as a dividing marker, okay? The dentate line usually is located 2 to 3 cm from the anal verge, no? If you insert your finger, no? Bilang ka 2 to 3 cm, nandun yung most of the dentate line, nandun lang siya. Okay, so everything above the dentate line, they are internal hemorrhoids. Okay, so usually, anong presentation ng internal hemorrhoids? Bleeding, prolapse, no? Thrombosis is very rare. Pain is can happen, but usually hindi ganun ka-painful. Hindi painful ang internal hemorrhoids. Okay? Anything below the dentate line o yun nandun na sa bungad talaga, no? Usually they are external hemorrhoids, no? So dito thrombosis may occur which can cause severe, doc. Minsan sobrang sakit pupunta sa iyo, doc, di ako makaupo, di ako hirap maglakad. Ayun pala pagtingin mo magana, no? Usually these are external hemorrhoids. Okay, so how do you stage hemorrhoids, no? But staging only Ginagamit lang natin siya for internal hemorrhoids. Okay, there are 4 degrees. Okay, first degree usually this is by symptom and by PE. Okay, first degree usually there's only occasional discomfort, some bleeding, no, but no prolapsing. Okay, if you insert your finger, minsan wala ka naman makapa masyado or may konti ka lang makapang mass sa loob. Okay, second degree, no, the hemorrhoids prolapse on defecation, but after defecation, they reduce spontaneously. Pag dumumi siya, yun, Dok. Pero pag naghugas na siya, no, wala na. Okay? Third degree, hemorrhoids on defecation but requires digital reduction. Okay? Lagi mo tatanungin, pagka dumi mo ba, pagka may lumabas, pagkatapos, ano, kailangan mo ba itulak ng daliri? No? Usually, these are third degree na. Okay? Fourth degree, hemorrhoids is prolapse and kahit itulak mo, they cannot be reduced. Okay? So how do you treat them? Okay? Treatment usually depends on the signs and symptoms, and it depends on the stage. So how do you treat external hemorrhoids? External hemorrhoids, usually these are very painful. No? Yung mga masakit talaga. Pag tingin mo, uy, nakaluwa, maga. Okay? Mapulang-mapula, no? Parang hematoma dun sa may puwet. Okay? So intense pains usually during the first 24 to 72 hours, no? Pag ganito, nakuha mo, kailan lumabas, Dok? Kagabi lang eh. Padumi akong matigas. Sobrang sakit, Dok. Refer nyo kagad sa surgery kasi this requires emergent surgical intervention. Okay? Kailangan namin i-drain kagad yan. Okay? But if after 72, kailan pa lumabas to, Dok? Mga 5 days ago eh. Ganyan. Pero masakit pa rin eh. No? Pag tingin mo, but hindi na ganun ka-tender. Okay? Usually by this time, after 72 hours, the clot begins to resorb na. Okay? And pain is less. No? Pain resolves spontaneously. Okay? Emergent surgical excision or drainage may not be necessary na. But kailangan pa rin. Okay? So what do you do after 72 hours? No? You can provide adequate oral pain coverage. Again, NSAID pa rin pinakamaganda. Okay? Kung walang contraindication sa NSAID pa rin ang bigay ninyo. Oral. Okay? I rarely, actually, I think most surgeons, they rarely use yung mga topical na eh. Okay? Kasi hindi talaga sobrang gumagana but hindi ganun kaganda. Okay? Oral pa rin ang pinakamaganda for pain control. Okay? You advise them warm sitz bath. Okay? Warm only, no? Very important. Warm. Okay? I always advise my patient to check. Pag umuusok yung tubig, hindi yan warm. Hot yan. Mamamaga. I have one patient before. Sabi ko, in-explain ko sa kanya, warm sitz bath only. Okay, pag uwi niya, ginawa niya, umuusok, bumalik sa akin after 1-2 days ata, mas maga pa siya. Okay? Kasi mamamaga talaga yan. Pag napasok yan. So, advise them, only warm. I always say them, pag kaya ng pisngi ninyo, no? Kaya niyo ilublob yung pisngi ninyo dun sa warm water na yon, that's warm enough. Okay? And upuan nila talaga. Hindi usok ang kailangan natin. Upuan nila, get a big batya, no? Or a big tub. Fill it with warm water. Okay? Ask the patient to sit, no? Soak nila yung puwet nila kahit na mga 5-10 minutes lang. No? 2 to 3 times a day. That will help talaga dun sa pain. Okay? And syempre, kahit na hindi na kailangan ng emergent surgical excision, you still need to refer them to surgery for more definitive procedures kasi pwede silang mag-recur. The pain can recur. Internal hemorrhoids, now you treat them depending on the degree. Okay? First and second degree, usually they only present with bleeding. Okay? What you do, you can do diet modifications. Okay? You can start them on stool softeners. Okay? Like mga laxative, mga ganyan. Okay? Mga Senalax, mga Senocot, mga ganyan, you can give them. Okay? You advise them increase oral fluid intake in order to help, no, yung sa stool. Kasi pag nadi-dehydrate ang patient, masyadong tumitigas kasi the body absorbs all the water. No, that's a function of the left side of the colon eh, to absorb all the water. So if dehydrated ng patient yan, expect mo the stool will be hard. Okay? And you modify bowel habits. You always advise them na, lalo na ngayon, di ba, ang sarap pag banyo, may cellphone ka na, may charger ka pa, then may Wi-Fi ka, no? Kulang na lang magkape ka habang jumijebs ka. Sorry for the term, okay? But you advise them, no? Go to the toilet only kapag talagang ayan na. Then labas, tapos. Do not stay there na naka-squat. It aggravates the hemorrhoids, okay? Advise them, pagkalabas, tapos na. Okay? So, that's for ano lang, no? Yung mga maraka na bleeding lang. But if there's persistent bleeding, okay, kahit na first or second degree lang, sabihin natin wala talagang mass na nakapaper, doc, medyo malakas yung bleeding eh. Medyo malakas siya, okay? Don't hesitate to refer to surgeons na, no? Baka kailangan na siyang masilip sa OR. Okay? But for prolapse hemorrhoids, no, these are third degree or worse is fourth degree, okay? No room for observation, no, you refer them to surgery. Some of them might need to be admitted pa nga for adequate IV pain control, okay? Then, para makita kagad ng surgeons, okay? Kasi this one, like yung ganito, yung tawag namin to cauliflower na to eh, no? Cauliflower na hemorrhoids na to eh. This can be combination of this can be a mixed hemorrhoid, no? Combination ng internal and external. And this one might require surgery na kagad. Okay? So again, the mainstay of hemorrhoidal management, okay? One, adequate oral pain relief, okay? Preferably NSAIDs, okay? Stool softeners, okay? You can give muscle relaxants, okay, to relax the sphincter. It reduces the pain and the congestion, okay? Okay, you can give topical analgesics, okay, but still oral pa rin ang required na, ang preferred, and warm sits back. Okay? And ang take home natin, I think this is my last slide, okay? Every time you're in doubt, no, in terms of breast and hemorrhoid management, you can always refer to us, okay, to the surgeons. Thank you.
Thank you po, Dr. Roque, for the very comprehensive lecture regarding breast and hemorrhoids. So for question po, from an anonymous attendee, pag nag-request ba ng mammography, do we have to specify right breast or left breast? Or is it understood na pag sinabing mammography, both breasts ang titingnan?
Yan, ito yung nakakatawa palagi dyan. Okay? Very, very good question, no? When we request for mammography, no, may common sense. Pag ginawa nila yan, automatic, bilateral palagi yan. Okay? Bihira naman tayo magpagawa ng left. Kahit nga na mastectomy na namin yung patient eh. Okay? When we request for ultrasound, no, ginagawa pa rin nila kahit yung mastectomy site. Okay? Now, pag mammography, pag nakita nilang post-mastectomy ang patient, hindi na nila magagawa yung post-mastectomy site kasi wala na silang iipitin. Okay? But, nakita nyo patient nyo, hindi mas post-mastectomy. Annual PE lang. Okay? Kahit ilagay ninyo, mammography lang. Okay na dapat yun, understood yun. You don't have to specify right or left. Kasi pag nagmammogram din tayo, we always want to check both breasts. Eh. Hindi lang naman left. Tuloy nakakapakong bukol. No. Hindi lang yun ang importante kasi gusto mo pa rin ma-detect. No? Ba't ka nagre-request ng mammogram? Is yung non-palpable na breast masses. Minsan, ano lang sila, nakaka-detect kami ng cancer na pinpoint lang. Tuldok lang. Pag tinignan mo sa mammogram, ito yun. Then you biopsy it. Cancer siya. So, always, when you request for mammography, bilateral yan dapat understood. Kung medyo duda ka doon sa gagawa ng mammography, better safe, mammography bilateral. Para safe na lang. Wala rin naman mawawala sa iyo doon.
Is there still a role for diosmin, hesperidine like Daflon in hemorrhoids or even in acute hemorrhoidal attack or even
yes,
in hemorrhoid management?
Yes, I still use them, no, the Flon. Okay. I still use them, but usually kasi ano lang sila kumbaga adjunct lang sila. Hindi pwedeng sila lang yung ibibigay mo, no? They can be adjunct, no, dun sa gagawin, but ang pinaka-importante pa rin kasi is yung na-mention ko, no? Adequate pain relief, warm sits bath, diet modification, hydration, and stool softeners. Then you can give Daflon. Wala namang masama.
For how long po, sir, yung Daflon?
Ako, I give them kahit na mga 1 week. 1 week kasi you need to see them eh. Let's say hindi mo naman kailangan i-admit ng patient. Okay? Give them Daflon, then yung mga listahan natin. And I always ask them, if you notice that the pain decreases or improves, okay? I can see you after 1 week. But if you think the pain progresses, no, or aggravates, okay, kahit 2-3 days, balik ka kagad sa clinic. Kailangan kita makita. Ibig sabihin, hindi gumagana. We might need to admit you and we might need to perform surgery. Yun. Okay, but ako usually 1 week.
Sir, how about Facto ointment? How long do you apply them?
Same lang with the Flon, no? Mga 1 week, no? Usually dapat kasi yung mga yan within a week nag-i-improve na yung mga yan. 1 week lang. Ako, bihira nga ako gumamit ng Facto actually. No? Bihira, no? But if gagamit man ako ng Facto, I usually use the suppository type. Kasi the ointment is very messy eh. Minsan pagkapahid mo, pagsuot ng underwear, pag-upo, nawawala din, napapahid, no? So I use the suppository para at least nandun sa loob talaga, direct dun sa vessels yung effect niya. But I usually use them kaya mga not more than a week. Less lang. Kasi pag more than a week, kailangan mo pa rin siya, you might need to do something na. No? Baka hindi na gumana yung ganong conservative management.
Sir, can the patient go directly for an MRI instead of mammo and ultrasound of the breast?
Pwede naman, no? MRI is also one of the good modality, no, to image the breast, no? But we rely muna on mammogram pa rin, no? Kasi too expensive ang MRI, no? Not everyone can avail of the MRI. Not all hospitals or institution has MRI set up din, no? But if institution has MRI, you can go direct to MRI naman. Walang masama. But still, guidelines pa rin kasi mammogram pa rin yung first screening. Kasi when you talk of the general population, magkano lang ang mammogram eh. I think mammogram costs around mga 2 to 3 or at most 4,000 pesos. A breast MRI will cost the patient mga around 20,000. So you cannot recommend that type of screening, no? That expensive to the general population. But if your patient can pay for that amount, I won't hesitate requesting for an MRI.
Sir, for symptomatic pregnant patient with hemorrhoids, what would be the best management po?
Symptomatic pregnant?
Opo, Doc.
I think same lang, no? I think the pain relievers, you can give them, as long as it's safe for the pregnancy, you can give the pain relievers. I'm not sure about the Flon, no? If you can give them through pregnancy, no? But most of my pregnant patients, I advise them adequate NSAIDs, warm sits bath, okay? Then you cannot give stool softeners kasi sa mga pregnant patients. So I advise them hydration, then diet modification. It will help. Kasi if you give laxatives, some of them might promote contraction, so not good. So I would not recommend those.
Sir, so in the interest of time, sir, we will now award the certificate of recognition. Thank you very much po.
Thank you, Doctora. Thank you. Thank you, everyone.